This is Dr. Sargisian, and today we will talk about exam one. This is exam one review lecture, and it will cover all of the topics you will have on the exam one. However, there are also some additional topics that came from readings and PowerPoints and additional materials posted in D2L. Health prevention and promotion are important topics in modern healthcare environment. I would like to make a side note that in pretty much in every subject, in every discipline in health, if you are taking an exam, please pay attention to the following. Before starting any pharmaceutical drastic interventions, try lifestyle changes. For instance, if patient presents with hyperlipidemia, it's always reasonable to start with lifestyle changes such as changing diet and exercising. However, in critical cases or in extreme cases when patient's cholesterol is very, very high, then you may opt for pharmaceutical interventions. And the same applies to many other conditions such as hypertension. And for instance, in hypertension, you may elect to proceed with dietary changes such as reducing salt intake and exercise. But if patient is in hypertensive crisis, obviously you will proceed with medication. So screenings have valuable place in health care, in health promotion and prevention of the disease. And but they are not really universal. They shouldn't cover every single patient of every age or gender. For instance, if you are scheduling for colonoscopy, for the screening, you should not just cover everyone and say, okay, every 10 years we will have colonoscopy. The guidelines suggest to do colonoscopy only at the age 50 and repeat every 10 years if needed. Not if needed, just for screening. Again, I'm sorry. So age 50 and screening every 10 years, but stop at age 75 unless it will be necessary. But the general recommendation is to stop at 75 if there were no adverse results during the previous screening. The same is vaccinations. For instance, pneumovac, you will not give anyone in pediatric populations, but you will give it in geriatric every 5 years. Obesity is an important disease in modern society, and I'm saying important because there are lots and lots of examples and cases. So the same way for the obesity, you cannot just start pharmaceuticals right away, something like phentermine, or even refer patient for bariatric surgery, but you can proceed with lifestyle changes. Again, you have to know your criteria. For instance, like introducing lifestyle changes, you should start when patient has BMI of 30. And there are cutoff points. So, of course, patient with BMI, let's say 26, may be overweight, but it's not obese. So there are no interventions per se necessary at that point. But at 30, you have to be very adamant introducing some interventions at that BMI. Functional assessment is another important topic I would like you to know. And in this situation, when you are performing functional assessment, please do not confuse it with physical assessment, because physical assessment is truly physical assessment. You are obtaining objective data during the visit, but functional assessment has a big historical component in it. So you need to have understanding what's happening with the patient. So in these two categories: basic activities of daily living and instrumental activities of daily living. Basic activities of daily living is something like eating, bathing, dressing, and instrumental activities. Good example used to be balancing checkbook, but today more and more people use online banking. You can say that instrumental will be like accessing their bank account online and paying their bills online. So, of course, you may also notice that instrumental activities of daily living would change. They will change as the humanity progresses, but basic activities pretty much stay constant. Next topic I'd like to talk about is cultural competence. And the cultural competence is important, especially in our diverse society in the United States. So you will deal, and you already do deal as nurses at bedsides, in clinics, and in healthcare centers with many people from different cultures. So it's important not to introduce cultural bias. And cultural bias means that you assign certain characteristics or belief to certain cultural group. However, it's important to maintain the individualized approach and explore patient beliefs, like it says here. Because, for example, someone is, let's say, Armenian, and a lady from Armenia who grew up in a rural region in mountains, she doesn't believe in prenatal care, and she may deliver the baby in her own home with no professional help. However, someone with the same background who grew up in the urban setting in the United States may elect to deliver the baby in the hospital and have all the prenatal care necessary. So, long story short, again, even these two ladies belong to the same cultural group and have same ethnic origin, they may be very different in their healthcare beliefs, in their needs. What do they need? And of course, this is somewhat hypothetical example. And in case of the first lady, you may provide more education about what prenatal care is and why it's necessary if you're dealing with them. And however, again, the environment will shape the beliefs of the patients, and those patients may be from the same ethnic or racial background, but they may have different beliefs and different needs. So what you do to develop your own cultural competence, you explore this patient's beliefs, and based on that exploration, you will be able to recognize what patient needs. And we need to avoid cultural bias, of course, by all means, because cultural bias is using cultural stereotypes to certain ethnic or racial group. Health literacy is important for patient in understanding the modalities of diagnostics and treatment, and that's why it's important to evaluate it. And also, this will help us to educate the patient in the way that patient will understand. So there are several tools that may help the evaluation of the health literacy, and First one is Realm SF. Realm SF is not perfect. It only evaluates medical word recognition, and it won't really evaluate how your patient comprehends written or spoken material. So, but it will help to see, do they know what the medical jargon, basically medical words and basically medical terminology. Another one is Ask Me 3, which I really like personally. And Ask Me 3 will say you have to actually teach the patient to ask you questions. Like first question is, what's my problem or what's my main problem? Second question, what I need to do about it. And third question, why it's important to do this. So example, what's my problem? You have diabetes. It means your blood glucose is uncontrolled, which in long term can cause damage to certain organs. And what do I need to do? You need to take medication. And third one, why it's important for me to do this? Because if you don't do this, this will have negative consequences for your health. And of course, I'm like somewhat exaggerating my speech in here, and every patient is different, but just as like the basics are here. So these three questions are very useful for patient to ask you, and then you can educate them based on their understanding level. The last one is nuanced vital signs, and it's the ability to calculate data, and also it will evaluate the general knowledge about health. So this may be helpful because when you are talking about lab work or medication administration and so on, self-medication administration, and I'm talking about oral medication, not even something like injections, that's still important to know. So okay, how we can make it better, what kind of interventions we can use to evaluate or not to evaluate, to address the health literacy concern. So first and foremost, assess the level, like I talked about these three tools you can use, and then based on the level you can educate the patient about their condition. And when you do that, printed materials are not really the best anymore, especially in some places I've seen the Xerox copies. They are like so old and so outdated. So don't do that. Or even pretty printed form is not really the best way to approach it. Alternative formats such as video recordings, podcasts, you name it, TV shows or radio shows, or something like that addresses their concerns, patient concerns about the disorder in non-traditional way, they actually bring better results. Let's talk about health disparities. And health disparities are everywhere. Even we are trying to provide the best care we can as nurses and nurse practitioners. That doesn't work usually universally. And what I'm trying to say, it may be an access issue because you may be the best nurse practitioner there, and I'm sure all of you will be great. But if patients do not have access to you, and then how we are going to deal with it. So, and access is an important issue because if there is no access, there is no healthcare delivery in this situation. So it's important to create a patient-centered environment And basically whatever we do, it's about patient. It's not about making profit, or it's not about meeting the whatever the reporting guidelines. So it's all about the patients, and we'll try to do that. So again, healthcare disparities may be resolved by creating free clinics. You may create more access, and there are ways to do it, but unfortunately it's there. So healthcare outcomes will be affected by the disparities. So the more disparities you have, the less beneficials, or the lower level outcomes you will have. So healthcare disparities are the determinants of healthcare outcome. And of course, healthcare disparities, it's not something like genetic or biologic origin. It's not like everyone is different because they are biologic, because their biologic makeup is different, but it's different because they live in different environment, they have different access, social status, income level, and that will affect the care outcome. So healthcare disparities are the main thing that makes the healthcare outcome worse. So another thing is clinicians' basis. We all have some kind of unconscious preconceived notions, and these notions may affect the care. It's important to be more forward thinking and not uh, be stereotypical, like people of certain income level, they will be known compliant, versus if someone is affluent, they will follow your treatment regimen and so on, so which is not really true. So you still have to put your best face and do your maximum effort regardless where the patient came from. Another topic, language as a barrier to care, and it's not about like people who do not speak English well, or but it's also about language as the literacy level. If we are dealing with people who do not know English, you may use translation services. And if it's the education level, we talked about it in previous one, it's important to assess the comprehension level and build your educational interventions accordingly. Next topic is genetics. We are living in very exciting times when personalized or precision medicine is developing more and more, and we are moving from empiric treatments towards more precise or tailored to certain individual treatments, and this is all based on genetic makeup. Some of you maybe witness it at the higher extent, at the bigger extent, and some of you didn't, but this is the direction we are taking, and more and more the treatments will be tailored to patients' genetics. Good example is Plavix, clopidogrel, and some people will be very responsive to clopidogrel therapy, while others will not be good candidates for it. And it's all based on their genetic makeup. So Punnett square, I want you to review it if you don't know, and I'm sure all of you know, but review the Punnett square because it's all important to differentiate between different type of genetic disorders, and I will talk about it in a few minutes in more details. Risk assessment is important component of recognizing patient's genetic makeup, or even creating personalized or precision approach to the patient, and how you would see the patient in the light of certain disease development. So risk assessment basically will help you to recognize the disease early, or even if the patient is asymptomatic, then to figure out that this patient is having a higher risk to develop certain disease. To conduct a thorough risk assessment, you need to do 3-generation family pedigree. And this may seem tedious, but again, 3-generation family pedigree will allow you to create a better picture and better understanding of the genetic makeup of certain individual. Next topic I'd like to talk here is direct-to-consumer testing. Direct-to-consumer testing or genetic testing, it's great because it's widely available in the retail. You do not need a receipt, and you do not need a prescription. I'm sorry, you do not need a prescription from the doctor. You may need a receipt, and you do not need insurance approval to do it, and you can get results pretty quickly. And direct-to-consumer testing will show some predisposition for certain diseases and also may address the ancestry. But what's the problem with it? It will not be predicting risk. So it will not be conducting risk assessment, because it may say, hey, you have predisposition to develop Alzheimer's disease, but in reality, risk of developing Alzheimer's disease will be so low in that individual, so it will create unnecessary worry. But again, this is widely developing field, and it may get better and may get certainly more regulated in the future. But another good use of this, of course, the ancestry and discovering your ancestral roots, and just finding relatives that were probably you had no idea you had. When we're talking about genetics, it's important to talk about Genetic Information Non-Discrimination Act, and this came into light or was signed into law by President George W. Bush on May 21st of 2008. Significant date to remember, because this is truly the first legislation that addresses genetics and genetic information. So what it does and what it doesn't do, it's not like this iron shield and protects everything in genetics information. Genetics information may be available widely. If it's public information for some reason, your genetic makeup, your genome, then everyone can address it. In the insurance companies and employers may use your public information. However, your insurer, for instance, cannot use genetic information, even available one, to make enrollment or coverage decision or how much premium you have to pay. So it's like having pre-existing condition. So on the other hand, insurer can ask for more genetic information to justify the coverage. So basically, I do not want to cover you as an insurance for a genetic disease that you do not have, or you don't have a risk for. So basically, again, there is that, I wouldn't call it a loophole, but the way to get out of this for insurer, or just make it more complicated for the patient. However, this is really a great achievement, because the main thing is that insurer cannot deny coverage. From the employer's perspective, this is important because employers cannot use genetic information to make hiring, firing, giving you promotions or a bonus or like retirement, whatever bonuses, privileges, compensation. So that's the good part. But again, employers may have access to the public information and genetic information available publicly, and they may know about it. However, they cannot build their employment decisions based on that. So again, GINA is an important piece of legislation, and it's not overly comprehensive. And I also put here, like in red and in bold, that GINA is not applicable for individuals who are already symptomatic, treated for, or been diagnosed with genetic conditions. So basically, if that information is available, your insurer may have access to that. So let's talk about genetic disorders. And again, your Punnett square is important here. Just in general, to refresh your understanding of this, you need to know how to approach patients when doing their risk assessment. When you're doing family history or pedigree and you're looking at generations, you may find some patterns that will clue you that yes, this is a autosomal dominant disorder, or hey, this is the recessive disorder. So that, like, simple patterns, autosomal dominant disorders, only one of the parents can have that genetic mutation, and it's enough to pass the disease to next generation. So, and it will express because you need only one copy of the gene. In autosomal recessive disorders, you need two copies of the mutation or two copies of the gene. So basically, consanguinity, if it's a marriage between relatives, it increases their frequency of autosomal recessive disorders because the likelihood of having similar genetic makeup is much higher between relatives than between complete strangers. So in autosomal recessive disorders, there is so-called horizontal pattern of inheritance because it will affect one generation, or like they say, like old wives' tales, it skips generation. It truly doesn't, but AR disorders will wildly express in one generation. So imagine that husband and wife, they both have the mutation for certain disorder, but they are carriers. So if you have the mutation but don't express it, and you have only one copy of AR, then you are carrier. But when they have children, there is high likelihood that all or most of these children will have this AR disorder. So you will have this generation of siblings that they will all have these disorders. And if they marry someone who doesn't have that recessive disorder trait, so their children or grandchildren of the original couple will not have it expressed, but they will be again carrier. X-linked disorders are very important because they are somewhat unusual. Of course, they reside on X chromosome. And it's important to know that if you see something that only affects male members in the family or in pedigree, that's something like probably X-linked disorder. And the reasoning behind it that males, we have only one X chromosome, and if there is a mutation, it will express. For females, there is a backup copy of X chromosome. So even if there is a mutation, it will not be expressed, and the female will be a carrier for X-linked disorder, while the male will have the expression. Also, the case when female has two X chromosomes with mutations, in this case, the disorder will be expressed, but likelihood of it is again much lower than having a male with single X chromosome. Big part of this examination is about aging and geriatric syndromes. But first and foremost, let's get one thing straight. Aging is not a disease. Being older is not a disease. We're all getting older as we speak, and everybody will be older. So this is not a disease. It's not abnormal. So if someone presents with low or high lab values, it is not normal. It's not a reflection of aging. So example, if you see low hemoglobin, it's anemia. It doesn't matter if the patient is 72-year-old or 84-year-old. Patient is anemic and you need to investigate. Because of that, I want you to know the patterns of lab value changes with aging. Again, even the lab values may be decreased, but they should not be abnormal. So at the end of the slide, there's the statement that lab value below above normal, it's not normal. It's pretty much self-explanatory. But again, it may be on low end because it's reduced physiological reserve of certain function that reflected in that lab value. So please remember that. But you may notice that the values are decreased. Normal changes with aging or expected changes with aging, there are several of them, and this is not comprehensive list, but muscle mass will decrease, especially if people don't exercise. Reduced bone density, especially if your patients do not exercise and don't do a weight bearing exercise, which is very important. Homeostatic mechanism are decreased. Immunological response, of course, will decrease. But all of this, they shouldn't be to the level of abnormal. So patient, for instance, for the last one, impaired immunological response, patient does not become immunocompromised when they are older. They may be responding weaker than younger person, but they are not immunocompromised. So please just know, and you already know, that the adults can be older and can be still relatively healthy. Geriatric syndromes are syndromes that pertinent to patients or people who are older, and this is okay, again, not it will not be happening with everyone, but it's common with aging. So first one I would like to talk is about elder drivers. And the reactivity time to events in our surroundings is decreasing with age, and there's really not much we can do about it. We cannot increase our reactivity and be like we were at 18-year-old. However, we can avoid situations where we are in challenging encounters on the road. For instance, some elder drivers will elect not to drive on an interstate, or if there is a visual impairment or some don't see well at night, they will elect not to drive at night. So these are recommendations you may give to your patients, but also at some point you may elect to report the unsafe driver to DMV or other authorities, whichever the state is it. And most of the states are require mandatory reporting of unsafe drivers. So again, please know that I'm using the word unsafe driver versus elderly driver, because someone can be very unsafe. They are even 32 and they are neglectful in their driving, versus someone who is 84 and very diligent and aware of their surroundings, and also they're doing all these precautions to avoid extreme driving situations such as high traffic or darkness or bad weather. So again, age shouldn't be this like category or the criteria, I'm sorry, to say, hey, she's old, then let's take her driver's license away, which is not appropriate. It should be all targeted on safety. Another topic or geriatric syndrome is elder abuse. Elder abuse is unfortunately relatively common, and CDC defines elder abuse like any abuse or and neglect of people age 60 or older by caregivers or someone who is in a role of caregiving or some type of relationship that expectation of care is elder abuse, and also expectations of trust. So basically elder abuse is the violation of trust, which is really none of us likes it. And unfortunately with elderly people this will happen because obviously elderly people are more vulnerable to many things, including violation of trust. So you need to know that there are several kinds of abuse, and it's actually 7. And it can be psychological, can be financial, can be sexual, can be physical, or can be abandonment, neglect, or also self-neglect. And you may say self-neglect, it's the person causing by themselves. However, yes, they do, but the caregiver or whoever is the person with the expectation of trust should be able to address it and help the patient who is exhibiting self-neglect. The important thing is, I know you cannot be in every house or in every skilled nursing facility and just look at every single elderly person who has a caregiver. But what you can do, you can screen for elder abuse anybody who is over 60 and comes to your office or you're dealing in the hospital. So screening for elder abuse should be this integral part of your care for older adults. And it's very important. So basically every visit you deal with every older adult, you have to on the back of your head, mind, whatever, you have to have screening for elder abuse. Failure to thrive is another syndrome, and you remember failure to thrive was in like can be applied to newborns, but also it can apply to elderly. It's a very comprehensive and complex syndrome. It will include loss of stamina, loss of desire to do anything, decreased function, complete deterioration cognitively, and progressive loss of energy, loss of strength, and so basically person truly is failing to thrive. The easy way to catch it is to look at the weight, because failure to thrive may be caused by many things, including the abuse and neglect, but also it can be an organic physical cause. And the easy way to catch it is to look for the weight loss. So you need to know that 10% weight loss is indicative of possibility of failure to thrive. If the weight loss is unintended, I mean, if it's intended, it will be great, especially for your professor now who's reading this lecture. But if it's unintended, then we have a red flag, because you should focus, and if you have deal with someone like this, you need to complete physical examination and just look for something like organ failure. It can be chronic infection, and the worst is, of course, malignancy, and very commonly it's a GI malignancy, upper GI or lower GI. So it's important to catch it early, because even it's called failure to thrive, it's not a death sentence, and it can be a reversible cause. And yes, we know that malignancy can be treated and go into remission, also, especially lower gastro GI intestinal malignancies can be treated very well. Let's talk more about geriatric syndromes, and there are a few more of them. Falls are relatively common, and there can be many factors affecting this. They can have multifactorial origin, and it's really important to do the prevention versus dealing with consequences of falls. So it's better to be proactive versus reactive. So it's important to review, especially if that's a home health nursing visiting, to review the surrounding of the patient and see if there's something like is happening in their surrounding. Do they have loose rugs or stairs to climb or uneven flooring, you name it. So that kind of one of the things. That can be environmental. The other thing, it can be something related to medications, and of course blood pressure medications, and on inappropriate prescribing of blood pressure medications can be very grave, can have very grave consequences in terms of falls, because it can cause the orthostatic hypotension, and a patient may fall. So to tag on that is let's go back to falls, I'm sorry. So it's important, if the fall occurs, to review all of the circumstances, the situation, what happened, and avoid those in the future. So if it's related to drugs, the drugs may need to be adjusted. So this is tagging on the next topic, polypharmacy, perhaps my favorite. So polypharmacy, it means many pharmacy or many drugs, medications, is the use of multiple drugs. It can be even appropriate use, not a misuse, but if we have more than 5, then we have polypharmacy. And 5, it's not a big number these days because it includes prescription and non-prescription. So you will see that in those situations will be you will see that in those situations that someone has using aspirin and has a proton pump inhibitor, cholesterol medication, statin, and beta blocker, and something else, hypothyroidism. So 5 is very easily achievable, and also they will take Tylenol on occasion, OTC. So it's not a big list. So, but important part of it, so also the inappropriate prescribing. So even if it's just one medication, but it's used inappropriately or prescribed inappropriately, it's polypharmacy. Another problem we have here is when you treat a side effect of one medication with another medication. Dehydration is another geriatric syndrome I would like to talk about, and it's fairly common in older adults, but it can happen in young people too. But older adults are more prone to this because it can be related to inability to move or mobility loss versus being on medications that increase diuresis and so on. So, or just self-neglect, but dehydration is also will cause negative outcomes much easier in older adults versus younger person. So easy way to put dehydration is that you have non-sufficient fluid intake to balance the excessive fluid loss. So basically intake doesn't match output, which will result in dehydration. It's easy to diagnose relatively. You can use skin turgor, or you can use just also the classic is a hematocrit hemoglobin ratio. So if that's 1 to 3 ratio is violated, then patient may be dehydrated. Basically, if the amount of hemoglobin is increased compared to hematocrit. Next topic is dementia delirium. I don't want to spend much time on this because we will talk about it in upcoming weeks, but you need to know that dementia delirium are also geriatric syndromes. Let's talk about end-of-life care. And end-of-life care is important because it allows people to die with dignity and die pain-free, hopefully, and die in the surroundings they like. Unfortunately, lots of people die in a hospital setting and they die alone. And so it's important to provide appropriate care and improve these conditions. And when I'm saying end of life care, I also would involve palliative care because sometimes it's the same, sometimes it's not. Patient may be on palliative care, but it won't be end of life. But palliative care is basically symptom management. Palliative versus curative. Curative will eventually cure the disease. Palliative will help you manage the symptoms, something like pain. So important these days to know that one person, one provider obviously cannot manage anything this complex. So it's important to have interdisciplinary approach for to deal with it. And there are many specialists in hospice. If you're a primary care provider, you still may be involved in the care of the patients, but if it's an end of life or palliative care, so you may need help from the hospice team. So palliative sedation and pain control, they all directed to easing the pain and making patient more comfortable. And there may be different levels of this. Some patients may choose to have no or very mild sedations, while others would like to be as comfortable as possible. Of course, some will not be able to express those wishes while they are having the illness, but it's important to develop those directives prior to someone getting sick and having to face end of life care. So 5 wishes approach is very good tool to use in these situations. And 5 wishes, it's 5 wishes of the patient, and they kind of overlap advanced directives. And but it's also simpler way to start the evaluation of what this patient wants. So 5 wishes is number 1 is selecting a person who will make healthcare decision for the patient when the patient cannot make them. So number 2 is the kind of medical treatment patient desire or doesn't want. Number 3, how comfortable I want to be, or basically level of sedation, level of pain control. And number 4 is how do I want people to treat me? And number 5, what I want my loved ones to know. And the last one is truly like patient confidentiality. You know, in old days, in mid 20th century and beyond, it was the opposite. They would hide the terminal diagnosis from the patient and saying, oh yeah, things will get better, you'll get better. Although when someone is dying, they obviously feel that the end is approaching, and it's not a surprise for the patient. And thankfully, the situation is changed now. Patient is in control, and patient will know what's going on with them, but also how much do I want to share with my loved ones about my condition? And so patient is in control. So please know these 5 wishes and how you deal with them. How to deal with common situations during end of life care. Again, you need team interdisciplinary approach. And in some rural communities, you may be fairly isolated, but again, always help available, and you can provide good quality of care at the end of life. So one of the phenomena that occurs at the end of life, it's anxiety. And management of anxiety may be non-pharmaceutical, such as guided imagery or therapy, versus pharmaceutical. And you can start using the traditional approach how to manage anxiety, start, let's say, with SSRIs, or it can be a more generous use of anti-anxiolytics. So managing dyspnea, how you would manage dyspnea for this patient. It's dyspnea or shortness of breath is not a pleasant sensation, neither for the patient or someone who is witnessing it, like family member, and it needs to be addressed because patient is suffocating, choking, and so on. So it's really scary. Fortunately, you can deal with it, and the best way to deal with this in end-of-life care or palliative care situation is to administer morphine. Morphine is universally accepted and it works very well. And on the other hand, you can use other opioids to work on dyspnea, and they also work. Xerostomia or dry mouth is decreased salivary secretion. Decreased salivary secretion, it's bothersome because it may result in many different challenges for the patient. So it's important to diagnose it and address it. So the easy way to diagnose it is cracker biscuit test. When you are giving a patient a dry cracker or biscuit, and if they chewing it but they are not able to swallow it, then xerostomia is present in this situation. Another option is the tongue blade test. Basically, when you're doing oral exam with a tongue blade, with a like wooden tongue blade, and at the end you are putting the tongue blade on the tongue, and if it sticks to the tongue surface, it's also it's xerostomia. So it's important to diagnose and treat xerostomia. You can increase fluids or give lozenges, and so there are so many options. And but it's important to address it because it also affects the quality of life. So last slide I want to talk to you about, it's the format of the exam. This is the first exam you take it in this course. It's open book, it's 60 minutes, and you will have 50 multiple choice. Most of them are multiple choice, or it can be multiple response questions, not many. So the questions, again, reflecting content from reading, from your study guide, from presentations, and from this exam review. So if you did all of that, you will receive a good grade for this exam. So secret to taking open book exam, knowing where your resources are, knowing where the information is. So you have to have your book available in printed or electronic format, and you also have to have your bookmarks available on the important topics. And also you need to have your notes available, and I would suggest to go over this review, and I also would suggest to do study guide very diligently and have those notes available. So the questions are randomized, and because of that, if two students, and I really hope not, taking the quiz together and hoping to look at each other's screens. I know none of you would do that, but the questions are different, so they are in random sequence. So, and the last thing I would like for you to know that sometimes there is an internet connection problem. So take that test your internet connection quiz that available, and you can take it as many times as you want to. And it's a few questions only, it's not 50 questions, and you can randomly click at the answers if you don't feel like reading the answers, reading the questions and answering it correctly. So do that, and see if you have any problems, please contact the appropriate support, like for D2L, and say that I'm having problem, or it may be your internet connection. Either way, but don't jump into a real exam without trying that test your internet connection quiz. So this is it, and I wish you good luck on this test, and you may contact me or your respective section instructor, and we'll be back to you as soon as we can. So I wish you good luck on this exam and have a good day.